Welcome, everyone. The session will begin shortly. Welcome, welcome. We're getting a few people coming in. We're going to give it a few more seconds. Awesome. I think we're good to start. Welcome, everyone. On behalf of NHF, welcome to Ankle Replacements and Bleeding Disorders, What's a PT to Do? My name is Adeli Lopez. I'm the HR Director for the National Hemophilia Foundation. For privacy purposes, please join us in renaming your screen by hovering over your image and clicking on the ... on the upper right hand of your window, then selecting rename and change your Zoom participant name to first name and registration category. So if you're a consumer, you can put in John, consumer, or if you're an exhibitor, Lisa, exhibitor, just for privacy purposes. Now, I would like to introduce everyone here joining us, but first, let's introduce Mark. Mark Gilganon is a physical therapist, has been a member of the University of Virginia Hemophilia Treatment Center for over 20 years, primarily a pediatric physical therapist. Mark has now expanded his role into the adult HCT clinic. He is currently a member of the NHF PT working group and is in the past filled the role of chairperson for the PTWG. He enjoys working with children of all ages and truly values the team he works with at the University of Virginia. He is an avid college and professional basketball fan, enjoys cycling and traveling with his wife, family, and friends, and looks forward to attending more conferences with the NHF PT colleagues. He's always willing to talk about all the Bruce Springsteen concerts he has gone to. Love it. Without further ado, Mark, take it away.
Good afternoon, everyone. I hope you can hear me okay. Happy Friday, depending whether it's where you are, afternoon or lunchtime. I'm glad you could join us today. I have the pleasure of introducing Michael Utek. He's our speaker today for our session on ankle replacements and bleeding disorders, what's a PT to do. Michael, if you don't know, is the clinical supervisor of the outpatient physical therapy division at MedStar Georgetown University at Washington, D.C. He's got over 20 years of clinical experience in orthopedics and adult hemophilia. He's recognized as an orthopedic specialist from the APTA, certified athletic trainer with the National Athletic Trainer Association, and a strength and conditioning specialist from the National Strength and Conditioning Association. Mr. Utek has been an instructor in continuing education courses to physical therapists for the Institute of Physical Art and has provided educational presentations to us before for those of us that work in the hemophilia community. Currently, Michael is director of the Functional Manual Therapy Residency Program at Georgetown. He's a native of South Dakota, enjoys hiking, travel, fitness, and enjoys making these presentations for us. So my pleasure. Michael, please take it away.
Thank you, Mark, so much. It's great. It's a pleasure to be here today, and I thank you all for joining me on this topic that I have found to come of interest for me lately, being that I work at MedStar Georgetown University Hospital, and we have two excellent ankle surgeons who are performing new ankle replacements. And so I've had the opportunity to work with a few of these patients. And near and dear to my own heart is my father's been suffering from ankle arthritis for probably about 20 years. I've been his physical therapist, keeping him moving for as long as I could. But about 3 years ago, the ankle arthritis got too bad that rehab didn't work any longer, braces didn't work any longer, shoe modifications and activity modifications didn't work as well. So we had a choice to choose what to do for surgery. And so I would like to kind of present a little bit about what we have here, what I've learned. I have no disclosures to report. What I'd like to show you a little bit today is that we're going to go over a brief ankle overview and then take a look at the treatment options our patients have. Ankle fusion, I will cover briefly, and then total ankle replacement, which I'll go over a little bit more in deeper detail. And then finally finish a little bit with rehab of what I could tell you about what we found in research. For our ankle overview, in hemophilia, approximately, as we all know, 70–80% of all bleeding occurs in the joints. The hinge joints are the most commonly affected, and therefore that we are going to see that the ankle joint often becomes one of these target joints. As we know, blood in the joint is never good. It will lead to synovial hypertrophy, recurrent hemarthrosis, and eventually leading to cartilage degeneration. End-stage arthritis is very debilitating. It will alter our patient's gait and often restrict them from being able to move around.
Michael, I'm sorry to interrupt you, Michael.
Yeah.
We don't see anything on your screen. If you can just share really quickly your screen. I'm sorry.
Okay.
I was really interested in seeing the PowerPoints. Like, it looked really creative.
They were there initially, right?
No, we stopped sharing for a little while so that we can all see you.
Okay.
And now we can redo the same thing. If you like, you can also send it to Hassan and we will do it for you.
One second. Now, are you seeing my screen right now?
No. Can the share screen on the bottom?
Yep, here we go. How about now?
Yes, now you want to put it in presentation mode. There you go.
Got it.
Got
All
it. Yay.
All right, sorry about that, everyone. Technical difficulties. So target joint with the ankle. Well, we find that when you have arthritis, end-stage arthritis in here, it is very debilitating and it leads to significant decline in quality of life and mental and health scores. Anatomically, we are looking at the ankle. It is known as the talocrural joint. It is formed by the distal tibia and fibula, where you can see that the talus articulates up into it. As we look at the middle diagram, we can see that there's an interesting arrangement of where the talus fits up into the distal talus. This is a configuration that we often call is the mortise. This feature makes the ankle the most congruent weight-bearing joint in the body. This joint endures more weight-bearing forces per square centimeter than any other joint in the body. That's probably why it was so difficult to find appropriate implants and replacements in the earlier years. The demands on this ankle are extraordinary. It must be stable and mobile. Biomechanically, we see that the axis of rotation around the ankle is inclined at about 83 degrees varus. The obliquity of this creates eversion of the foot as the ankle dorsiflexes and inversion of the foot as the ankle plantar flexes. The ankle is the most commonly injured joint in the body, and this injury often can lead to devastating long-term effects down the road. Here, we're seeing that we have what it looks like if we have end-stage arthritis. On the left, we see that we have smooth articular surface in the picture with wide joint spaces. And on the right, we have an end-stage arthritis. Well, we can see that there is obliteration of the joint space and there's bone-on-bone contact. What are the treatment options when we get to this route? Well, first of all, we want to make sure that we exhaust all conservative care. And this can include intensive prophylaxis with factor concentrates, using non-steroidal anti-inflammatories, orthotics, braces, footwear modifications, and activity modifications. And then often the doctors were often trying to do cortisone injections. When we get to the end of it and none of that works any longer, we have two options. The first one we see is the first one that we see over to the left is your total ankle arthroplasty, or also known as replacement. And on the right, we see is ankle arthrodesis, which is known as fusion. You'll see me probably use the more common, easier term of fusion and ankle replacement. Ankle fusion. This is when the surgeon removes the ankle joint by basically compressing the bones together and attaching them with plates, nails, screws, and essentially turning this ankle into one solid bone. It is classically known as the gold standard for treatment of end-stage arthritis, and its pros is that it provides good pain relief, has excellent patient satisfaction scores, and it is durable. Once you form bone around this joint, it should last forever. Ankle fusion, we see potential outcome complications that can occur. It is known that if we lock up the talocrural joint, there's going to be more stress to the adjacent joints around it, such as the subtalar and midfoot. So down the road and years, we'll often see that there might be a potential for arthritis. And this is why doctors started looking for replacements. And then also, it's not uncommon that even though you get a fusion, the patients will have excellent pain reduction, but it might not be 100%. It is not uncommon for 25 to 50% of these patients to still have some pain. Probably before surgery, they typically would rate that they had 8 out of 10, and after surgery, they're likely saying, I only have 1 out of 2 out of 10 pain. It allows them to now function and have a life again. Other complications, there is a little bit of decreased functional ability because of that loss of range of motion at the ankle. It will make them a little bit harder to traverse like hills, occasionally stairs, and any uneven surfaces. As with any surgery, there's always risk within it, and we see that the non-union rate currently is about 7%, and risk for infection is about 3%. Here what we see is a chart that I picked up from the American Physical Therapy monograph on ankle replacements. And this provides a summary of outcomes following all ankle fusions in 6 separate studies. Specifically, we'll take a look at the third row down, the Coester study. This study had the longest follow-up of the patients at a mean of 22 years. What is interesting, if we look further across, that they had an incident of about 91% evidence of subtalar arthritis. However, the patients were still reported very good satisfaction with the procedure at 67%, and 88% of them would still have this procedure again. If we look at the study below that, again, we look at the Fuchs study, we go across, we see that they had a mean follow-up of 23 years. And in their study, they had 100% of all their outcomes. But what's interesting in this study, what you don't have on the graph, is that 1/3 of the patients did report that they had a professional handicap as moderate and another third as significant. So we see that many functional mobility limitations may come, adjacent joint arthritis may be present, but despite these problems, patients continue to report high levels of patient satisfaction. Now it's gonna take us here a little bit to total ankle arthroplasty. And what I need to cover is a little bit of the history to understand why it got such a bad rap initially and why fusion became the gold standard And so what we see in that is the first generation of implants that were developed for arthroplasty was done in the 70s. And they were horribly plagued with unacceptably high complication rates and poor long-term survivorship. What we found is that the designs were highly constrained, meaning very restricted, and they were of two-component design prosthesis only. They used cement fixation on both the talar piece and tibial side. And what we found was that implant loosening occurred in staggering percentages of 22 to 75%, often within the first 2 to 3 years. Some of this can be attributed to that we had a poor surgical technique at the time, the implant design was not good, and this all led to wide osteolysis of the bone, subsidence, which is where the prosthesis actually sinks into the bone, and then of course mechanical failure. As you can imagine, this would lead to really bad patient satisfaction scores, causing the medical community at the time in the 70s to pronounce that ankle fusion is the gold standard. But in time, progress occurs, and we are now on third and fourth generation total ankle arthroplasty designs. We can categorize these designs by the number of components that they have, which will be 2 or 3, and the device type, which we will call fixed and mobile bearing. The two-component system, which we're going to look at, is an A and the first one is A. This is where the polyethylene spacer is actually the plastic piece is attached to the tibia portion. And then we look in the 3-component design. This design allows for independent mobility of that spacer of plastic to articulate between the talus and the tibia. So it's much acting like a meniscus of the knee. Other innovations that we see currently going on with implants and replacement is that there's been better designs in the plastic we're using, such as an ultra high molecular weight polyethylene. And what this basically is a super strong plastic that is very resistant to compression. We are now not cementing our prosthesis. The doctors are using a porous coating along the implant, which allows that the bone can itself integrate into the implant and become more stable. Doctors are using much more smaller cuts, which are helping us not to have as many intraoperative fractures. The doctors have also learned that ligaments are very important for stability to a joint, so they make sure they repair them if they seem to be a little lax. And then finally, doctors have learned that it's very, very important for anatomical balancing. And what we also see is now we have the capability to use surgical mapping using CAT scan imaging. Currently in the United States, well, currently in the world, there are 20 plus replacement designs. There are only 7 approved by the FDA in the United States. They are the Eclipse, the Inbone, the Infinity, the Star, the Salto Talaris, the Topaz, and the Zimmer Trabeculae. The top one there, the Agility, once was one of the first ones approved, but it is fallen out of favor because of poor complication rates, and it is no longer on the market. However, I left it on there because sometimes patients are still coming in with it, and the doctors are needing to do revisions of this type of, and there still are revision pieces to do it available on the market. Now let's take a look how are replacement outcomes. What we're finding in the research is that they have significant improvement in pain and function, that they're able to maintain the arc of motion of the ankle. And because of this, it provides a little bit superior performance of walking on uneven surfaces compared to a fusion. What's really great to see now is that the survivorship of these implants look to be at 10 years around 70 to 90% viable. And I would definitely want to make it clear to everyone, so far there's no evidence that one of those prostheses of the 7 that I mentioned before is better than the other. They all pretty much look the same at this point. Indications. What are the patient selection factors we want. Being that the replacement is a mechanical piece and all mechanical parts, as we know, will wear out at some time, it is best to employ this device in older patients. And preferably in the literature, it's always saying over 50, but it's very common now that doctors are performing in people in their 40s. Also, the population should basically have a low physical demand. We should have good bone stock, good vascular health, no immune suppression, and good rear foot alignment are all necessary factors. What's interesting though, if a patient is going to have bilateral ankle arthritis, it would not be preferred to do 2 fusions because the outcomes functionally are very poor. So in this situation, doctors would really rather go with a replacement, at least with one of them. And also if we see if our patient has significant subtalar arthritis as well as talocrural arthritis, then likely the doctors are going to recommend replacement, because if you're going to lock up the talocrural joint, then that subtalar joint is really going to be stressed more. And of course, that's going to flare up the arthritis in that situation. Contraindications of why we wouldn't do a replacement. If the patient has peripheral vascular disease, we need good vascularity going down into that leg. Peripheral neuropathy is a contraindication. Avascular necrosis of the talus, unhealthy soft tissue, and if there's a large alignment deformity, preferably of the hind foot, the doctors will not perform an ankle replacement. And often physical therapists do not get the chance to ever see a surgery. And so I included in my presentation here, we have a video that will show us a total ankle replacement performed in about 4 minutes. I'll try and keep up with it if I can. This is a device made by the Wright company. This is the Infinity implant that we're going to see, so they're not all the same. What is first done is that the doctors are going to take a CAT scan of the knee to the foot, and the images are then going to be sent and fed into a website software that can help the doctor plan preoperatively the surgical needs of the size and fit of the prosthesis. Specifically, this company can make patient-specific alignment guides for the talus and tibia. There's going to be a 10 to 15 centimeter cut anteriorly. Then the tibial alignment is going to be brought in. And then we're going to use scanning to see if we have that correct alignment. If it's correct, we're going to make our marks. We're then going to go ahead and bring in, this is basically a sizing guide. We're going to use a scan again to make sure the size is fitting into the joint as the doctor wants. If that works, the drill comes out and they're going to mark the corners of the mortise joint of where they're going to put the implant. Now they bring in another guiding or a jig that will help the doctor make the appropriate cuts along to remove any of the arthritis that's in the tibia. Then comes the talar component. They are going to check that they're getting the right alignment with the talus that they want. This is the device that helps guide the doctor to get the removal of the arthritis found on the talus. And then we're going to do a trial of the tibial component. They're going to punch a couple pegs into the bone if this was the right size, and that will help fix the implant in. Then came, we have now all the components in there and the doctor's looking for fit. And then we're checking range of motion, seeing if the fit is working, if anything's moving. The rear pieces are moved out. And now we're going to start working on the talus again. What we're going to see here, the doctors are going to try and create more of a doming effect around the bone. So they're going to remove an angle on the posterior aspect. Now they're going to come to the anterior aspect, and they're going to use drills to get the right depth that they want into the bone. And then they're going to use a burr to smooth it out. And then we come in with more drilling at a different angle to create this doming arc effect that the doctor's looking for. And then smoothing it out again with the burr. And you can see here is that you get this kind of rounded surface in which it will help the implant sit and fit a little bit better in. Now they're testing the mobility of the trial pieces. They just put in a couple drills for the tailor peg for where the implant will insert into. Here comes the tibial implant. You can see the porous surface right there is where the bone will grow into. And it said that that was cement that they put in, but they actually don't do that. They put on a hydroxyapatite coating, which is a coating that helps the bone fuse to the implant much faster. They have a protection spacer in. Here comes our talus piece. They put the hydroxyapatite coating back in. The classic hammering that is always done by the orthopedic surgeons. And now we're going to bring in the polymer section of that piece, and it's going to go into the tibia, fixed into the tibia. And this is basically the joint spacer and helps better mobility. They're checking the motion. It looks good. The doctors will be happy. And that's what it should look like when it's done. And then arthroscopic, or a couple of weeks after, this is what we'd like to see on x-rays. Now that we've looked at both of these procedures, why don't we take a look at what research has to show us on arthroplasty? An excellent article that I found, which was in the Foot and Ankle Clinics of the North America. It was a review article done in the 2017, and they did a comparison of the research of ankle arthrodesis versus total ankle arthroplasty. What they found, the take-home points for fusion is a definitive, safe, and reliable procedure to relieve pain and improve function. Fusion can also be performed using a variety of techniques, allowing flexible surgical planning, which is something all doctors love. There is no definitive activity restrictions after a fusion. So basically patients can go back to running, can go back to jumping, but you don't really see that happening. But it is possible, but it doesn't often occur. And we see that there is going to be compensatory increase in rear foot and midfoot motion after this procedure. And this is actually great because this will help the ankle be able to walk. It'll give it a little bit more plantar flexion and dorsiflexion, and that's going to come from the rear foot joints and the midfoot joints. But once you stress these joints over a period of time, literature suggests that the fusion can accelerate the progression of rear foot and midfoot joint arthritis. Now, what are the take-home points that the research found in replacement? And again, we see that there was a survival rate of the replacement in the patient at a 75 to 90% at 10 years, that there was no difference in complication or infection rates in obese or diabetic patients, that the arc of motion is maintained in replacement compared to a fusion. Replacement gait pattern was more closely resembled that of the control group, which was what they saw in studies, and the control group was normals. And that they really recommend that the young and active, highly demanding patients with arthritis may better be candidates for fusion than replacement. So in conclusion, in this study, they basically said that total ankle replacement has emerged as a viable and often preferred option by the patient, but it is vital that the patient is counseled in the pros and cons of both of these procedures. Several factors are strong reasons to favor a fusion over a replacement, such as if a patient does not have protective sensation or if there's any clear neuropathy going on. Overall, the choice must be tailored to the individual patient. That'll take us to another study Unfortunately, there are no randomized controlled studies, and therefore what we have to do in science is rely on a collection of all the research we find, which would be a systematic review, and then running it through a meta-analysis. And here they did that just recently in 2020. They found 35 articles from the years 2006 to 2016. So what we can see here that these are very modern techniques and modern processes being used. Data extracted is that they found about 4,000 replacements and about 1,000 fusion procedures. And what we see that there was only about a 5-year follow-up on the studies for replacements and only a 4-year study follow-up on fusions. There were no complication rate differences between the two, which we can see here. Replacement was at 23.6% complications, and fusion had a 25.7% rate of complications. Revision rates were no significantly different, but there are a big limitation in the study is that we're only reporting on a 5-year survivorship. So more long-term studies are definitely needed to see what this is going to look like in 10, 15 years. The conclusion for this study by the doctors was that the decision between these two should be made again on a case-by-case basis. And then my favorite of all of the research I found out here was done actually by the doctors here at Georgetown University Hospital. Dr. Sackstein was a fellow of hematology. Dr. Paul Cooper is an orthopedic surgeon. And then Dr. Craig Kessler is our primary lead hematologist at Georgetown. And they did a comparison systematic study of looking at total ankle arthritis patients undergoing replacement. What they identified was 41 studies. And after excluding criteria, what we really only found was that there were 5 studies which could be utilized. They were of level 4 evidence, but they were well-designed, single institution, retrospective case studies. This is what we're going to find in the data. Here are the 5 studies. And what we see across the top of this graph is that how many patients were involved. I'd like you to all take a quick look at the mean age that we see here. Of all these patients receiving total ankle replacement, there seem to be in their 40s to 50s, which we said usually this is a procedure that is intended for older patient populations. And then we're going to look at across the top is that we have a lot of pre-operative and post-operative scores that I'd love us to take a look at. The SF-36 is a form that is done, that is reported by the patients on how they perceive their health. The AOFAS, that is the American Orthopedic Foot and Ankle Score, and that is a score that is rated by the physician on how they perceive it came out. And then finally, we have the range of motion scores. And once we take a look at these studies, we can see if we look at the BARGE study at the top, and if we move across to the preoperative scores under the SF-36 score, we see the scores jump from 30 to postoperatively to 83. So we see significant improvements. Again, the other study that we looked at, PRIES, which is down a couple levels, they had a report of 38 score preoperatively, and afterwards, patients were measuring their health had improved to a 77 point level. If we move over to the next column, we're looking at the physician scores of how they standardize their outcomes, and what we see, we have dramatic improvements again, from 38 to 81, 40 to 85, 23 to 76. And finally, in the last column, we see is that we have the range of motion. And again, we see there was good improvement and increases in range of motion. But in all studies, we also found that there was significant complications that we had. What we'll look at is infection rates. There was 2 infections. When we say this, we say deep infections within the prosthesis in 84 of the total ankle replacements performed. There was only 67 patients in the studies that we collected, but a couple of the patients had bilateral replacements done, and so that's how we get to the number of 84. And it's most interesting if we go back to the other one. The 2 people that actually had the infection rate was in the Strauss study. And if you look back at the Strauss study, which is the second one from the bottom, and we move over, we'll notice that 50% of the patients in his study all were HIV positive. So with some immune compromise, we would expect to see a higher complication rates, and that's what we see here. Intraoperative fracture that occurred, it occurred in 3 patients, which was at a 4.5%. Arthrofibrosis, which is stiffening of the ankle, and that occurred in about 4.5% of the patients. Delayed wound healing in only 2 of the patients, and surprisingly, and lovingly to see, there was only 1 failure of the prosthesis loosening in 1 of the patients, which is about 1.5% in this group of people. And what we found in survival rate in hemophilia patients was looked at an Ecker study. He actually did a 10-year follow-up report and found that hemophilia patients had 85% survival, which is very good comparative to the 90% we see in the general population. So in summary, there really is no debate. What we all know that we have different individuals, and different individuals need different procedures. Both of these procedures are viable, but there are with some caveats. Fusion, it reduces pain, it improves function, and it is durable, but likely leads to adjacent joint arthritis. Replacement, it reduces pain, improves function to a fuller extent, thanks to the ability to have the motion over hills and on level surfaces. It preserves the range of motion, but will wear out at some point, and we also see there's slightly more complications. So how do we make a choice? What are you going to go with? And this is kind of how it's grouped down to. Fusion is most appropriate for a younger patient type, which would usually be less than 50. Patients who are going to have higher impact activities in their life, or a job as such, if they're a laborer, will need a fusion. If the patient has a large deformity, extensive bone loss, or if they had a previous infection, fusion is the more appropriate surgical technique to go with. Replacements, what we're really going to find is that older patients are going to take these. Being that we only have a 10-year survivorship, we're not going to have to do that many more revisions in older patient populations. We also will think that the older patient population will have a lower impact in activities of their daily living. With replacement, we have to have minimal deformity in the ankle. There needs to be good bone stock, and other indications of why you would choose replacement is if the patient shows that they have subtalus arthritis as well as talocrural arthritis. It's going to be better that the patient has replacement over a fusion. If you get a fusion of the talocrural joint and you have arthritis in that subtalar joint, it's not going to be great. So, so some doctors have fused both of them, the subtalar joint and the talocrural joint, but what they found is there's a lot of non-unions in the high percentage of that. So in this type of patient population, we would really probably prefer to go to replacement. And that brings us down to what a PT actually needs to know about rehab. It is really up to the PT to be the superhero in this, and what we need to do is establish realistic expectations with our patients who are going to undergo or are considering undergoing total ankle replacement. We need to educate them about what will happen before, during, and after. Pain following the surgery is to be expected. It is pretty significant, but it does improve over a period of time. replacement can actually be an outpatient procedure where you go in and out the same day. But with hemophilia patients, we're often going to see them a 3-day or a 3 overnight stay to monitor their factor levels, bleeding levels. When you come out of that surgery, you are definitely going to be in a splint or a cast, and you can be expecting to have that on for 2 to 4 weeks, or likely even longer in some doctors' preference. You are going to have to stay non-weight bearing for 2 to 6 weeks or longer, preferring if there was any complications that occurred. We're going to need to progress you to weight bearing, and we're going to do that via using a walking boot. And if you're going to have a replacement, don't expect to have full recovery until about 3 or 6 months. And to be very, very clear, if you have an ankle replacement, you are not going to improve your range of motion. What we see is the range of motion you have going in to the operation is the range of motion you're going to pretty much have when you come out. There's not going to be that much improvement. For the physical therapist, at the first, if you get the chance to have a preoperative visit, I need you all to evaluate range of motion, strength, and gait, particularly taking a lot of look at the health of the elbow and the non-surgical leg, and making sure that they're going to be to withstand the forces to be able to do crutch gait walking. At that first visit, I definitely make my patients all go through trial uses of crutches, making sure they do non-weight bearing, having them go up and down stairs, have them getting in and out of the bathroom non-weight bearing. And a lot of the patients who have gone through the surgeries thank me profusely that we did this in the clinic, which they kind of eye rolled at me, but found that when they got home, that was a very precarious situation and how they were going to get in and out of these situations. And then if the patient, we identify there are any weaknesses in the elbows or non-surgical leg, a strengthening program should be provided so we can address that so they can have a successful outcome. What the physical therapist must do, you have to get the post-operative report. Why? Because it can tell us a lot. One is it may identify any additional procedures that the doctor performed, such as an osteotomy. These are performed if there was some alignment issues and the doctor had to do some bone cutting. This will change the length of time in which the patient will need to heal and likely the rehab. Tendon lengthening. If the doctor is, after putting in the prosthesis and they find that they can't achieve about 5 degrees of range of motion, if they can't of dorsiflexion, then often they will use an Achilles lengthening procedure. And that is going to change the total rehab protocols, completely change. And then occasionally the doctors will see that there is significant subtalar fusion and they may fuse that. So you'll definitely want to be aware of that. And there may be an intraoperative complication such as a fracture, which if we look at the picture over there, we see that the medial malleolus suffered a fracture during the implant placement and they had to pin it. So this is going to slow down the patient's recovery. It should be okay, but the physical therapist obviously is going to need to be fully aware of this. Physical therapists, you have to know the specific surgeon's postoperative rehabilitation guidelines. All the doctors all have different guidelines, and so you better be sure that you're following your doctor's specific guideline. And typically what I've encountered often is that not all surgeons believe PT is necessary. What does the research tell us about postoperative management following an ankle replacement? Again, a systematic review that was done in 2021. We found that there was 85 studies met the inclusion criteria. And what we see, that there was absolutely no consensus by the surgeons on the most appropriate post-operative management, which entails like how long they should be immobilized, when non-weight bearing should be lifted. Then we also look at, there's a lot of conflicting opinions regarding how rehab protocol should look afterwards. So I'm going to now try and provide you some post-operative guidelines. And where the heck am I getting these from? Since there is no consensus, well, we're going to use some of the experience that we've gained at Georgetown. And also I've been able to find from the American Physical Therapy Association, created a module on ankle rehabilitation after replacements. And this was done in 2010. And then I used another research article in 2018 by the Italians, and the article was titled Total Ankle Replacement, Indication, Rehabilitation, and Results. Our primary goals in the first 0 to 6 weeks is just to keep it simple. We want that wound to heal. We want that implant to get really fixated into the bone. So we are not really going to be allowing a lot of motion. We want that leg in a cast, in a boot. And you are going to see significant amount of swelling in the ankle following this. So we need to combat this by keeping that ankle elevated, preferably like we see in the picture to the right. I like to have them have that ankle higher than the heart if they can. Or if they're going to be sitting in a chair, at least get that foot up on an ottoman. We are going to see a cast is going to be likely utilized for the first 2 weeks, if not longer, and you will slowly transition from a cast to a walking boot. There will be no weight bearing allowed usually for the first 4 to 6 weeks. And then at Georgetown, we have been starting very simple active range of motion, active assistive range of motion in the dorsiflexion and plantar flexion plane only. And then what I also like to employ here is definitely see if we can do some lymph massage drainage. After the 6 weeks, that's when physical therapy will really start to pick up and will be more vital to the patient. Our goals here are now kind of really be able to help that patient get back to gait training. And so we're really going to work on weight acceptance onto that leg and ankle. I like to employ the use of the bike at about 6 weeks. I find it's very good a mobilizer for the ankle and easy for the patient to perform. Aquatic therapy has been found to be extremely helpful. Once that wound heals, we can drop the patient in the water. They start to feel like they have their whole leg back again. There's less pain on the ankle when they're walking on it. And if we can get the patient to start restoring some normal range of motion and movement, that is fantastic for the brain and all the neuroplasticity that can occur there. Proprioception drills. What the heck can we do at these drills? I like to keep it very simple. A lot of times I'll just have the patient be sitting in a chair, put a big ball underneath their foot at home, and have them just roll that ankle forward and backwards, getting nice ankle motion and coordinating that with the knee. We also can do circles, so we can try and work on proprioceptive and kinesthetic awareness. And the focus really in this phase from 6 to 12 weeks is going to be on ankle range of motion and some isometrics. We will do some light TheraBand progressive resistance exercises, but again, the doctors are being very conservative about what the forces we're putting through. Finally, at the 3 to 6 month mark, what we're really physical therapists are gonna try and achieve is that we make sure we get dorsiflexion and plantar flexion mobility back. We wanna see if we can get to 80 to 100% of what the doctor achieved. And you're gonna know that if you have that post-operative report. At this time, we're really gonna start kicking up the ankle resistive strength training. We're going to try and get them to do, obviously a lot of calf raises, doing calf raises to single calf raises. These are great to be done in the pool and slowly progressing to land. And specifically, I find it very, very important to do task-specific training with the patient. What do they do in their social life? And try and work on those type of activities. And education. We want it to be very clear to these patients. We want to avoid high impact activities for the long term, which means no return to running or jumping. And finally, physical therapists, we're all going to set them up with an independent program and that they can continue on for at least a year. And I would focus mainly on calf strengthening, stretching, and also, of course, I will include in here balancing. So what activities can a patient return to after having a replacement? We have seen a lot of our patients go back to playing golf, hiking, biking, and swimming. All these activities are fine. And the only research article that I could find on physical therapy's influence on total ankle replacement was this one that recently was published in 2020. And what they found was that patients perceive physical therapists to be very valuable after this procedure. We also saw that patients who had physical therapy had greater physical function outcomes compared to those who did not. We also see that the highest physical functional scores were found in those patients that stayed in physical therapy longer and had more visits. So again, showing our importance. And then finally, I'd like to just note that it was definitely shown that these patients were all giving a self-assessment score, and they scored very low in the domain score in physical function and social participation, suggesting that postoperative care at these domains will better increase the value of this surgery, postoperative care, and physical therapy. Here are my references. And thank you. And I think we'll now open it up for comments, questions.
Awesome, awesome presentation, Michael. Thank you very much.
Thank you.
And what great presentations do is brings out some great questions that people have submitted. So let me share those with you. And we have about 10 minutes. So the first question we had to do with, can you do a total ankle replacement after a fusion or after a fusion has failed?
Yes. So can we go from fusion to replacement? I specifically found one really good article on that, and then I talked to our doctor who has successfully done it. It's not easy to do, but it can be done. And the research articles that I have read on it is that it was successful and the complication rate wasn't that bad. But I would preface this that it's not a normal joint, and so there is going to be more challenge to the surgery. And so I would expect that we could likely see more complication rates. But the research says that you can go there. And on the flip side, you can go from a total ankle replacement that maybe has failed, and the doctor can flip it back to doing an ankle arthrodesis or fusion. So both options, you can go either way.
Great. Another question was asking if you're familiar, have you worked with anyone that had the total ankle replacement and they've had it last greater than 10 years?
I have not. All my patients let's say, I worked with patients who had the earlier prosthesis, which in the first generation, and they all failed. They never made it to 10 years. The current prosthesis that I'm seeing, third generation, which hasn't been around enough, the longest patient I've had currently is 6 years. He had them both done bilaterally, and he is so happy. He is traveling the world, which he said he wouldn't have been able to do prior, and he has a great success with it.
Another question for you. Someone was just asking about some clarification about the research articles that you presented. The data that you were sharing, were those research articles, some of them with the general population and some with the hemophilia population, or were they all related to hemophilia?
So the first two articles, I believe I presented, the one in Foot and Ankle Clinics and the other one in Orthopedic Review, that was the general patient population. Sorry, not being clear on that. Then finally, the third research article I did focused completely all on hemophilia patients without the general patient population.
All right, great, thank you. Another participant sent a question. Could you comment again on the topic when you were discussing the bilateral ankle arthritis and subtalar arthritis and how those affect the decision for fusion versus replacement? I think they just want a little clarification on that.
I kind of just hit that. I knew that would be a follow-up. So if the patient has bilateral arthritis in the ankle, end stage, the doctors are definitely not going to want to fuse both of those ankles. We have in the clinic, I have patients who have both ankles fused, and if you watch their gait, it is the most bizarre thing you'll ever see. They're not in pain, but their functional mobility is definitely affected. And so therefore, that's why they're now saying that they would not want to fuse two ankles ever any longer. If possible, there's times you just can't, you have to do fusions. But if they could do one fusion and one replacement, they're going to see it's a better outcome. And then when we go to the, let's say, subtalar arthritis, if the patient has talocrural end-stage arthritis and the doctors see that there's significant subtalar arthritis, what they wouldn't want to do is just fuse that ankle, because a lot of more motion is going to happen at the subtalar joint. And if they already have arthritis there, that is likely going to become another source of pain for them. And therefore, the doctor would say, well, let's fuse that as well. And they end up usually with a triple arthrodesis. It's like 3 joints get fused. What they find the complication with that is that there's really poor bone union because of all the stress that occurs, that there's no motion that can occur anywhere. And again, if we think about how much force comes all the way down into that tiny little space of your whole entire body weight there. So if you fuse all those joints, subtalar, talocrural, you're gonna have poor results usually, is what we're seeing in the studies. There's high percentages in complications. Mark, you just went muted.
I know people like that.
Same here.
Have you seen as a complication consistently any leg length discrepancy?
Well, I'm working with the hemophilia patient population, and so there's so many comorbidities of the other joints of the knee, kind of maybe having a slight flexion contraction on the other side. So there have been some leg length discrepancies in these patients. I usually kind of can correct them out if necessary with, you know, a heel lift that can go into the shoe or orthotics. But I would say if you're just generalizing that, am I seeing that ankle replacements are having a lot of leg length discrepancies after that? And I would say no.
I got 2 more questions for you. Someone would like to know if you have any experience doing any pre-op training before the fusion or the replacement are done with patients.
Only with my dad. So you just don't get the doctors to get the patients to us early enough, you know. And a lot of the patients that I work with here at Georgetown, they come from far distances away, so they can't always get that. But with my dad preoperatively, I did work with him. We did see that he needed to definitely work on his tricep strength for those crutches to be non-weight bearing. And then we found that to traverse the stairs in the house that they have to get in and out of the house with crutches, non-weight bearing, was hugely difficult for his good legs, supposedly. And so we did a lot of strengthening on that as well.
Man's a lucky guy. He's got a good game.
Yeah. I'm not sure he says that. You know what they think of us at PT is pain and torture. So That's all I seem to give him.
Hey, I guess as we're getting near the time, one comment was to ask you, could you address the importance of having these procedures done in an HTC setting and how, we have some consumers on board with us today too, and just how important it is to have that teamwork between the surgeon and the HTC team.
Yeah, so it's extremely important to have your HTC team there. Again, at Georgetown, we see many patients from rural areas that come from, I don't know, a day's way. And we make sure that if we can convince them that they need to do their surgery here at Georgetown, so our doctors and nurses and physical therapists can be there to give them the appropriate care that they need. That it's very important before any of these replacement surgeries that you have to have that appropriate factor level. And I'm just always worried, are they going to get that at a hospital that doesn't have an HTC center? Our HTC center has had to work with other hospitals outside in the rural area, but we pretty much always try and convince our patients to come in.
We love our team.
All right. Thanks, Mark.
All right, so folks, if anyone has another question, we're going to wrap up in a minute or so. Michael, it's been a fantastic presentation. Thank you so much.
Thank you. It's great. It's now time for Manhattan on a Friday, so it's been a pleasure. And
Everybody on the West Coast, we're leaving. We're done for the day.
Yeah, exactly. We're done for the day, 5 p.m. here. All right.
We have one more question popped up for you. How widespread is surgical competence for this procedure, for the replacement? Are there a lot of surgeons that do it?
Yeah, I didn't cover that in my talk. This surgery is highly technically challenging, and research has shown that complication rates that are high is due to surgeons' incapability. And so, yes, you definitely need these doctors to have, and also research is showing that a surgeon's experience definitely improves the outcomes. And so you really do want to find an excellent surgeon who has done preferably hundreds of these, which they never have because there aren't 100 to perform. But on that caveat, I will say I love our new doctor who's brand new out of school. He is fantastic. He's up to date on the newest technique. He's performed a couple of the surgeries that I've worked with, and they've all been great.
Super. All right, we're just about wrapping up. They're going to shut us down. So thank you so much, Michael. Really appreciate it. Everyone, thanks for attending and enjoy the rest of the conference.
All right. Thank you, Mark. Thank you, everybody.
All right, thanks.